think the most important place to start is recognizing the importance of discernment. Now, I think this word gets used a lot, and people don't always understand what discernment means. Discernment means the ability to reflect internally what feels true and right for your body. It might not be true for everyone else, but it can be true for you. You can use logic and intuition in order to discern if something is right for you. It doesn't need to be one or the other. And so what you're going to learn through these modules is being able to discern what feels right for you. It's not about black or white, right or wrong, you must do it one way. This is about really deciding what feels right for you internally so that we can create the conditions in your external environment for you to feel safe, calm, and confident. The first thing that I want to talk about is choosing your birth team and figuring out what environment feels the most supportive for your body. This decision belongs to you and you alone. And like I said before, there's no right or wrong way to decide which environment is for you, as long as you're choosing for yourself and you're not feeling influenced to birth in a particular environment because you hear it's better. So you should ask yourself, what conditions, either internally or externally, do I need to help myself feel relaxed and safe in my body? Another important thing that is worth mentioning is, how do you make choices? Do you make choices from a place of fear, anxiety, or stress? Or do you make choices from a place of calm, inner confidence? The goal is that you can make choices that feel calm and confident and right for you, and that you aren't being led to make choices from this place of frazzled, frantic, stressful energy. And how does your body respond to the choices that you make? This is going to be very important and a theme that we continue to revisit throughout these modules together. Now, the first environment that I'd like to talk about is a hospital environment. It's really important to know that in a hospital environment, there are certain conditions that we cannot control for, whereas there are other environments where we have a lot more say in how we control the environment and who's in it. When you are in a hospital, you are dealing mostly with nurses who are taking direct orders from your provider. And those nurses are reporting back to your provider, who is not present at the hospital until you're really ready to have your baby. So at the very end of labor, when you're almost ready to meet your baby, then your provider shows up. There are some exceptions, like there are hospital midwives that do show up maybe through labor sporadically. And yes, there are some doctors that also can show up and show their face and make an appearance, but most likely you're going to be working very closely with those nurses. Hospitals often have arbitrary time limits. For example, in my area, there are certain time restrictions for how long a patient can push. We'll get more into this later. Other time limits are how long your bag of waters can be broken before a provider is going to want to intervene. Another general guideline around arbitrary time limits is that hospitals are very focused on patients making progress in however your provider deems is the normal progression of labor. What I mean by that is that they don't like to see labor plateau or stall, and sometimes they can be a little impatient when labor is slow. So I do think it's important when you are factoring in your decision of where you'd like to give birth, how do you do with certain parameters, certain time restrictions that might not be within your control. I also want to stress that most hospitals require monitoring for you and your baby. And so what that looks like is you're wearing a belly monitor. One is measuring the strength of your contractions, and the other is measuring baby's heart rate. These monitors can be worn either throughout the duration of your labor, or they can be worn intermittently. And in order for you to get intermittent fetal monitoring, which would mean then you are able to move around the room, you're not tied to the hospital bed, you can use the bathroom, you can take a shower, you can walk the halls, you have to request it. So it's not something that's just given to you. So I want you to make a note of that if you are planning to choose a hospital birth, that you ask your provider, can I have intermittent fetal monitoring? Now, when we get more into monitoring later, we're going to talk about, what needs to happen in order for you to have intermittent fetal monitoring. Baby has to look really healthy and mom has to look really healthy. Otherwise, your provider is going to want you to wear the monitors all of the time. I really want to stress too that nobody in this day and age, I don't care how great your hospital is and all the reviews you've read online, nobody should be giving birth in the hospital alone. It's just really difficult. Number one, you're focused on having a baby, so it's hard to advocate for yourself when all of these physiological processes are happening. So it's important that you have a support person, whether it's your partner, whether it's a mom or an auntie or a cousin or a sister or hired support like a doula. It's very important that you have someone there just protecting you and looking out for you. Another thing that is worth mentioning about a hospital birth is that there could be concierge fees that go with the doctor. In my area, a lot of the good doctors, some of the best providers charge a concierge fee, which ranges anywhere from $2,000 to $5,000. And this may be covered by your insurance, but usually it's not. And that concierge fee is paid to your provider directly. And sometimes these concierge fees is, allowing you direct access to the doctor. Some of them guarantee delivery, meaning they will for sure show up at your delivery. Whereas if you don't pay a concierge fee and they work in a larger medical practice, they might not be the ones delivering your baby. If that's the case, I highly recommend you meet your provider's backup provider in the event that they don't show up to your delivery. Another thing I'd like to mention about hospital births and the environment that you choose is your access to water. Some people really feel strongly about birthing in a tub or having access to labor in a bathtub or in a shower, and you might not have control of the room that you are assigned when you show up in labor. So if that's something that truly matters to you, then I highly suggest you have a conversation with your provider when you're still pregnant and say, I really have a preference for water. Is there any way you can notate on my chart that I would like to have a hospital room with a tub or a shower, and I'd like to labor in water if possible, if everything is healthy and normal. Another thing I'd like to mention about hospitals is it's very important to know if your hospital is a teaching hospital, because if it's a teaching hospital, there might be students in the room, residents in the room, and it's your choice if you want them in the room. So your provider might say, oh, well, they help me and they work within my practice and, they support me. But you need to understand, as a patient, not only are you a patient, but you are a paying customer of the medical establishment. So not only do you deserve to be treated with respect and integrity, but you have so many choices you get to make along the way in a hospital birth. When you choose a hospital birth, it's really important that you call your insurance and you find out what your deductible is, so you have an idea how much money you're going to be paying out of pocket, and as much as you can, account for any hidden fees. Don't just assume that a hospital birth is going to be cheaper, because sometimes it isn't. When you choose to give birth at home or a birth center, you choose a provider that is monitoring you, but not in the same way that they do in the hospital. There's also less interventions, so there is more freedom to move around. There is more choice in how, your environment is set up. You can birth in a tub, you can take a shower, you can hang out in bed, you can eat, you can be mobile, and sometimes there are restrictions in a hospital setting that might prevent you access to those things. When you're having a hospital birth, you work specifically with a midwife. Midwives use something called a Doppler periodically throughout labor to monitor the baby's heartbeat. Midwives usually do not show up until active labor starts, so if you want to give birth at home, you need to understand that you might be doing some early laboring at home with just you and your partner. Midwives often do not accept insurance. Midwives essentially can create something called a super bill, which then is submitted to your insurance on your behalf, and you may or may not get partial reimbursement. You can also use money from a health savings account to pay for midwifery care. That can sometimes offset the costs. There are major differences between working with a midwife and working with an obstetrician. And it's really important that you understand both philosophies so that you can choose what feels right to you. In order for me to explain the differences between a midwife and a doctor, I think it's important to talk about liability and how a midwife and a doctor might assess risk when they take on a patient or a client. There's a term used here frequently in medicine, and it's called defensive medicine. And it's this idea that sometimes obstetricians, when they provide care to their patients, they often make decisions or suggest certain interventions that protect them legally, but may or may not be in your best interest. Now, when we talk about an OBGYN or an obstetrician, they are going to inherently assess risk differently than a midwife. OBGYNs go to medical school and they become experts in high risk, complicated births. What do I mean by this? High risk means something different depending on who you ask. So it's really important that when you're using your discernment and you are interviewing with a provider, that you ask enough questions to determine, okay, how they're describing risk, does this apply to me? So for example, when it comes to assessing risk, let's take age. Anyone 35 and over, an OBGYN is going to consider high risk, or essentially there's a term called geriatric pregnancy. Not very nice, but they have to factor in age to them as something that makes someone high risk. Whereas a midwife, age is not a risk factor in and of itself. They are assessing risk differently. They're looking at the whole complete person. Did they have any underlying health conditions before they got pregnant? How is the baby developing in utero? They're really factoring a lot of things, so they're not just looking at age alone and making that become a risk factor. So because of the nature in which OBGYNs assess risk, they are not experts in normal, healthy, physiological birth. And if there is a patient that presents as healthy, everything is normal, there is a tendency for that provider to make someone high risk because that's their specialty. That is what they're good at. They're good at looking for problems. And thank goodness we have good providers that can assess risk seriously when there is an underlying issue. But if everything is healthy and baby looks normal, choosing an OBGYN might not always be the best option for some people, but not everyone. Some people just feel comfortable in the care of a doctor, and there is nothing wrong with that. The other thing to note about obstetricians is that they are very skilled surgeons. They can perform surgical procedures, more specifically a cesarean birth. And yes, I'm calling it a birth because it's still a birth. Whereas a midwife, they are not surgeons. Midwives are experts in normal, healthy, physiological birth. They are not capable, nor are they trained to perform any surgical procedure. There are different categories of midwives that are also good to understand. The first being a licensed midwife. Now, a licensed midwife goes through rigorous school and training, and they have to get a license in order to practice as a midwife. There's also a certified nurse midwife. These are midwives that have special extra schooling in nursing. There are also lay midwives, and those types of midwives tend to work underground. And they may or may not have any formal clinical training like a licensed midwife and a certified nurse midwife. Now, midwives can work in the hospital, they can work at birth centers, and they can work in home settings. When midwives work within a hospital setting, they are usually overseen by an obstetrician. That might not be universally true everywhere. There might be some midwives that work independently, but I would say in my area, in a lot of hospitals in the United States, they are overseen by an obstetrician. Midwives and obstetricians have very different philosophies when it comes to understanding the human body, physiology, and how birth unfolds. And I think it's important for me to talk about some major differences between the two schools of thought. The first one being vaginal exams. Doctors often during labor, sometimes before labor starts, active labor, when someone's pushing even, they might do frequent vaginal exams. To some people, that's not a problem. They're okay with that. On the flip side, some of my clients and a lot of women feel that vaginal exams can be very intrusive. And so many people prefer less frequent vaginal exams unless it is medically necessary. Midwives often do not frequently check for cervical dilation or effacement. So if a midwife is concerned that something is not normal, they might want to do a vaginal exam. Otherwise, they don't need to do a vaginal exam in order to see if their client is progressing or not. Another major difference in terms of the different schools of thought is how the nurses approach labor and birth. Nurses are trained, once again, like doctors, to intervene because they want to help labor along. And so they might not be as patient or as slow to watch to see how the birthing person's labor is unfolding on its own. They might be coming into the room frequently. They might be talking to you in the middle of labor when you're having a really strong contraction. They might not be sensitive to the fact that you are in labor and you might not be able to communicate with them in that moment. When it comes to nurses, you are essentially on their time because they might have to care for 6, 7, 8 patients at a time, going from room to room to room. So they might not be as aware or even really concerned what it is that you need to feel calm and confident. So there's a way for you to give birth in the hospital so that the nurse is on your time as opposed to you, the patient, being on their time. And that is really having to do with claiming the space, recognizing how we create an environment that feels right for you, which we are going to talk about later on. And in a hospital setting, again, because of how they're trained to be super vigilant and just aware of risk and liability, they might be more quick to intervene unless you, as the patient, as a client, talk to them in advance and tell them, listen, I don't want interventions unless it is medically necessary. And I want to have a conversation with you when you notice that something is medically necessary. I want to be aware of what my options are first so that I can decide what's right for me. We will talk later about the different kinds of medication that are offered in labor and birth in a hospital setting. But for now, you just need to know that hospitals have much more availability for medication than out-of-hospital births do. One other very important key difference between midwives and doctors is this concept of medical informed consent. Medical informed consent is this idea that a doctor or a midwife is sitting down with you and making you aware of what your choices and options are. And if there is a real medical reason to intervene, they are giving you that option. For example, I see this a lot in hospital settings. A nurse might come in and say, oh, your doctor called and said, that you're not making the kind of progress that we would like to see you make right now. So we're going to go ahead and start Pitocin now. That is not informed consent. Informed consent would be, hey, how are you feeling? We've kind of noticed that your labor has sort of slowed down a bit, and I know you're super exhausted, so we had this idea maybe that we would offer you Pitocin. How do you feel about that? Would you like some privacy to discuss this with your birth team? If that doesn't happen and someone is coming in the room and asserting themselves and saying, well, this needs to happen right now, first of all, there are very few situations where you have to make a decision on the fly. And when you are in that environment, you leave it up to your provider who you have entrusted to guide you through your experience to make the best decision. But more often than not, you are going to have time and space and privacy. And sometimes that is teaching your partner how to ask for privacy and space. Okay, nurse, I hear what you're saying. Now, can you come back in 5 minutes so that we can discuss this in privacy? When you work with an obstetrician, there are questions you can ask them in order to figure out, are they the right fit for you? The first question I highly recommend asking your obstetrician is, what is your cesarean birth rate? That question is essentially asking them, of all the patients they have, how many of their patients end up in a cesarean? If the cesarean rate is high, that is something to consider, especially if your goal is not to have a cesarean. Another question you can ask them is, does age alone classify me as high risk? And why? Why is that? The last question I highly recommend you ask your obstetrician is, can you provide an example of a patient that disagreed with your medical opinion, and how did you handle it? This is really important to pay attention to how your doctor responds. If they respond defensively, that might give you insight into how your labor might feel with that doctor. For midwives, I would ask them, of all of the clients that you take on, how many of your clients end up transferring to higher level of care? Meaning, how many of your clients end up transferring to the hospital? If your midwife's transfer rate is high, again, that's something to consider. Oh, why is it high? And maybe that opens up a conversation with your midwife. Another important question to ask a midwife, especially if you're having an out-of-hospital birth, is about meconium. Meconium is a very fancy word that we use to describe the baby's first bowel movement, and sometimes that happens before they're born. It's important to ask the midwife what happens if meconium is present in labor and see how they might handle that particular situation. Some midwives, by default, if they see meconium present, will transfer the client to the hospital. Other midwives might feel okay with meconium present depending where the client is in labor. If it's at the end of labor, they might treat it differently than if it's at the beginning of labor. Another important factor into choosing which birth environment is right for you is if you would like an additional support person, such as a birth doula. Not everyone needs a birth doula, and to be honest, that's why I started making these modules, because I feel it's important as a birth doula to share my education and my knowledge supporting hundreds of clients both in hospital and out of hospital, just so you're aware of what your choices and options are. But a good birth doula can be super helpful, especially in a hospital setting, because they can help you get space and privacy to make decisions. They can also ask nurses questions in order to get you more information about making a particular decision. Doulas really are a buffer for you and your provider. They're a buffer, but they're also a bridge. So a good doula is not confrontational, but there is an eloquence in how they're able to connect with your provider, with perhaps nursing staff, with a midwife assistant, whoever is in your birth environment. They have a way to connect with them neutrally, with you as the client in mind. There are different types of doulas, and I feel really strongly about making you aware of the different types. So there are doulas that call themselves natural doulas. These are doulas that believe that birth should unfold naturally. They might not be the most knowledgeable or the best fit for you if you are in a hospital setting and you end up needing medical intervention. They have a particular preference about how labor and birth should be, and that's fine. That's their choice. There are also birth support people called birth keepers, and those are not doulas. Birth keepers usually are not comfortable in hospital settings, and if you're planning on a home birth and for any reason you need to transfer, they might not have the knowledge or the skill set to support you in the hospital. Then there are doulas that call themselves home birth doulas. Similar to a birth keeper, they only want to take on clients that are choosing home births. Again, they have a preference about how labor and birth should unfold. This is a really personal choice to have a doula. And if I may be so bold, I think a good birth doula is someone that has a very neutral presence. It's someone that is not going to impose their belief system on you as the client. They are someone that is going to support your decisions even if they don't agree with them. And you won't know that they don't agree with you because they don't show it, because they know that the most important thing is for them to be a loving, supportive presence to you and your partner. The other thing to know is a good doula is also a good educator. They're there to help you understand what normal labor and birth looks like. They can also help you understand when something might be a special circumstance and when you might need medical intervention. What it boils down to is what company is most supportive to you and your body. For example, as a birth doula, I have seen sometimes the pregnant person's mom really impacting how the birth is unfolding. Any support person you have, whether you hire a doula, whether your mom is there or your sister or your aunt, it needs to be someone that is going to be a neutral, supportive presence. If there's a lot of emotional charge, or if you feel like you have to look after or sort of host someone during your labor and birth, I highly recommend choosing someone else, because that can really sort of change the trajectory of your labor and birth. There's a somatic component to giving birth, obviously. We are in our bodies when we give birth, and we have to learn how to shelf the mind in order to yield to what the body is trying to communicate. So you'll hear me talk about, what is your body communicating with you? And are you listening? Is it speaking the same language as your mind? And if not, it is an opportunity to bring them more in alignment with each other, to the point where your body is able to be in the driver's seat and your mind can take a back seat, because it's really hard to give birth when you're in your mind. Choosing a provider is similar to dating. On paper, a provider might seem like a good fit. They have all of the qualifications that meet what you're hoping to find, and they match your criteria perfectly. But then your body might be subtly communicating to you that you don't feel safe, or there's some sort of disconnect. So again, refocusing on how your body is communicating to you, particularly while you're still pregnant, so that you can start to create those conditions in your birth environment that can support you. There are certain clues that your body tries to communicate when something feels off or when something doesn't feel right to you. For example, you might feel a tightening in your abdomen or in your seat after you have a prenatal visit with your doctor or your midwife. You might feel anxious or nervous as your provider speaks to you. If you feel like your provider is talking at you and not with you, if you feel rushed or pressured to make a decision quickly that's not considered a medical emergency because your provider hasn't given you a medical reason to intervene, again, that is a red flag, and that's something you need to consider. And this really gets at the heart of somatic awareness, which is how the body is metabolizing fear. When you feel the sensation of fear, you are signaling to your body and your baby, it's not safe, don't come. And it can absolutely impact your labor. It can stall labor. Sometimes it can prolong labor, and sometimes it can stop labor altogether, which can be really exhausting and frustrating for the person in labor. Now, I want to transition and talk a little bit about estimated due dates, because there's such a hot topic, especially when it comes to choosing a provider. There are different ways you can calculate your estimated due date. And there are some providers that don't even give you a due date. They're rare, but they're out there. They tend to be midwives. But when it comes to obstetricians, they give you essentially this estimated due date. And generally speaking, you have up until 42 weeks gestation for you to go into labor. Estimated due dates typically are calculated off of last missed period, or if you're going through IVF, they're based off of that transfer date. If your cycle was regular and normal prior to becoming pregnant, that last missed period date tends to be the more accurate estimated due date. Due dates in general matter a heck of a lot more in a hospital setting than they do out of hospital. Well, why is that? Because in hospital, many patients experience the pressure of needing to be induced by a certain number of weeks gestation. For example, in my area, many providers often want to induce a patient by 41 weeks. Legally, medical providers, whether you have an out-of-hospital birth or in-hospital birth, you have until 42 weeks gestation to have your baby. However, in hospital setting, many providers want to induce their patient at 41 weeks, not 42 weeks. The reason that you're more likely to be induced at 41 weeks is because there's a relative risk of stillbirth after 41 weeks. I say relative because it is a very, very small risk, but it's still there, and it does increase slightly. You can obviously research what that relative risk is, and you can make an informed choice should you find yourself in that scenario. It is worth reviewing with your provider what makes the most sense for your body and your baby. Ultrasounds. They're very popular. And as a doula, I think a lot of clients, they just love to see their baby on an ultrasound. It makes them feel good. It allows them to connect with their baby. But I think it's important for you to know that the FDA does not condone frequent ultrasound usage. But as a doula, I have clients that are getting ultrasounds at every prenatal appointment throughout pregnancy. So the question becomes, well then, how often is too often? And that's when your discernment needs to kick in, and you need to figure out what makes sense for your body and your baby. If you're healthy, your baby's healthy, and everything is growing normally, you don't have to get an ultrasound if you don't want one. What we know about ultrasounds is that the high frequency sound waves heat tissues. So what does that do to your baby? It's heating the developing tissue. When someone gets an ultrasound, they're measuring baby's size, and they have something called growth percentile. Babies move around in utero, so when they're using high frequency sound waves to capture an image, that image has a lot of room for error. And so if someone gets an ultrasound and they're told, oh, your baby looks really big, we might need to induce you, that might create a lot of fear and anxiety in that person. And it might not make them feel calm and confident that they can go into spontaneous labor on their own. The other thing to note about ultrasounds is they tend to overestimate baby's size, again, because babies move. And so it's convenient if the baby's bigger. That's such a common reason to induce a patient, is because of a big baby. Also, it's important to note that you can deliver a healthy baby that's big, and there's nothing wrong with that either. Most of the time, baby size is not an issue. There are special circumstances that we'll get to later, but all in all, just use your discernment. If you want to check in to see your baby, that's perfectly fine. Just be mindful of how often you're getting ultrasounds, and be very careful if people share information with you that make you start to doubt if you can go into spontaneous labor on your own.